Hello to those of you who are coming in. We're going to give it another minute or two to start, but we're happy that you can join us. All lines are muted to prevent background noise and echo, but we would love to hear from you throughout this session, so feel free to use the chat box or the Q&A feature, and we'll get started very shortly. Another note is that if you are going to use the chat box, there is a drop-down menu that you can choose whether you want your message to go to just the panelists or if you want the message to go to everyone. So if you have a question, it'd be great if you can choose panelists and attendees so everyone can see your feedback. That would be great. So I believe we'll have more continue to join us, but we have a very packed session today. So I'm actually going to go ahead and get started. So hello and welcome to those of you who are in the virtual room today and those who are watching the recording. This is our second session of our webinar series on addressing barriers to diabetes prevention for older adult residents of public housing. My name is Ariel Mather, and I'm the program manager of the National Center for Equitable Care for Elders. This is a collaborative activity with the National Center for Health in Public Housing. And you can see that we have another guest speaker today for our second session, Dr. Albert Huang from the University of Chicago, and I will introduce him very shortly to you. All right, so we're all very familiar with Zoom reminders at this point, but again, all lines are muted, but we would love for you to utilize either the chat box or the Q&A feature to pass along any questions or comments you have, especially around your work related to diabetes with this population. Both this session and our first session from last week are being recorded or were recorded. We'll put a link in the chat box to the YouTube link for our first session if you were not able to join us for that. That was also emailed out to folks, and we'll send a reminder email as soon as the session wraps for that. We'll also be sending the slide deck after the session wraps for your reference. And we would certainly love to hear your feedback. We will have a survey pop up at the end of this session. We'll also get email to participants. We'd love for you to take just a few moments and give us any of your thoughts and opinions on this session. I won't spend too much time on this, but we always plug the priority topics page for COVID-19 on the Health Center Resource Clearinghouse page. This is a fantastic resource, especially as the vaccine program at health centers is going strong. There's a lot of great resources here. And I also won't spend too much time introducing our center or the National Center for Health and Public Housing, but we would love for you to stay connected with us after this session wraps. We would love for you to be on both of our mailing lists and to stay in touch about any future training and technical assistance activities. So just quickly, that's information about our NSHAPs. And throughout this two-session series, these are our learning objectives. We focused on a little bit more on this third learning objective around community programs and advocacy organizations focused on nutritional assistance last week, as we had a special guest speaker from the Massachusetts Council on Aging, focusing on nutrition. But generally, we're wanting folks to walk away understanding environmental and personal factors that influence the ability of older adults to engage in healthy lifestyle behaviors, which is really relevant to both diabetes prevention and treatment, which we'll talk both about today. And then, of course, identify strategies for effective case management that can address some social determinants of health that do impact diabetes, especially in this population. So without further ado, our guest speaker has lots of things on his plate today. So we're going to allow him to present his content first, and then we will transition to additional context from Dr. Jose Leon from the National Center for Health and Public Housing. So if you have questions during this next portion for Dr. Huang, we encourage you to put them in the chat box or the Q&A feature as soon as you have them, and we will take a pause before we go to the next portion of the webinar so he's able to address those. So let me read the quick bio of our guest speaker today. Dr. Albert Huang is Professor of Medicine, Director of the Center for Chronic Disease Research and Policy, and Associate Director of the Chicago Center for Diabetes Translation Research at the University of Chicago. He is a member of the Professional Practice Committee of the American Diabetes Association. Dr. Huang is a general internist who studies clinical and health policy issues at the intersection of diabetes, aging, and health economics. His research has provided the evidence-based foundation for the concept of personalizing diabetes care goals, as well as the contemporary natural history of the disease in older people. Dr. Huang's research has directly influenced modern diabetes care clinical practice guidelines for older people that now emphasize the individualization of glycemic goals, the role of patient treatment preferences, the clinical importance of hypoglycemia, and the management of geriatric conditions. So welcome, Dr. Huang.
Thank you, Ariel, and I'm very excited to be here and happy to speak with you. Next slide. And certainly, this is a small enough group that if you have a really urgent question, please send in through the chat or question and answer function of Zoom. So this is a brief outline of the talk I'll do today. I'm going to describe to you the heterogeneity of older adults with diabetes. And that heterogeneity influences how we approach prevention, both in terms of lifestyle changes, but also in terms of how we establish goals of diabetes care and establish a management plan for an older person with diabetes. And certainly for older adults that are in public housing or being seen in federally qualified health centers, even in that environment in particular, you're going to encounter people that aren't completely representative of what was seen, the kinds of patients that were enrolled in clinical trials. And so we have to account for that heterogeneity in our approach to prevention. Next slide. So the first section, I'll cover what we know about the heterogeneity of older adults with diabetes. Next slide. This graphic is data from the National Health Interview Survey showing the prevalence of diabetes, just diagnosed diabetes, starting in 1997 through 2004. And it shows that the prevalence of diabetes is steadily risen over time, up to, it's now close to 25% of older adults, people over 65, have type 2 diabetes. Another 50% of people over 65 have pre-diabetes. So hyperglycemia is very, very common, especially as people get older. So the point of this is to show you that it's a growing population, growing prevalence as our population ages, and diabetes should be viewed as a disease of aging, and due to both insulin resistance, but also declining insulin production from the pancreas. Next slide. That growing population of older adults with diabetes has direct consequences for our Medicare program, because people over 65 are all eligible to have Medicare. So the cost of diabetes care among older adults can be directly viewed by looking at the Medicare program. This is a forecast of Medicare spending on diabetes from 2009 into the future through 2034 that we did. And each of the different colored bars shows a different, basically a different cohort of older adults developing diabetes, and then basically the cost of that care of caring for their diabetes gets accounted for in Medicare spending. And you can see that our projection was that the cost of diabetes care for the Medicare program would triple over this period of time due to basically baby boomers developing diabetes, the next generation after that, the light blue having diabetes, and so on. So the combination of both the country aging, but also the country being relatively obese, with nearly 40% of adults having obesity, the combination of those two factors leads us to be concerned about the overall spending on diabetes for the future. Next slide. So that's certainly all very concerning for us as providers, but also from a public health perspective. But how does this relate to heterogeneity? So one way to characterize the heterogeneity of older adults is to think about all the co-occurring conditions that travel with diabetes. And so this table shows you the kind of the correlation of type 2 diabetes with other conditions like coronary artery disease, CAD, congestive heart failure, urinary incontinence, which is indicated by UI, falls, and so on. And co-occurring chronic diseases or multimorbidity is basically the norm for older adults with diabetes, with nearly a quarter having coronary artery disease, 10% having heart failure, and then another nearly 30% having incontinence and falls. And you can see that it's very common for people to have more than one condition, well over 50%, and then nearly a quarter having at least 2 or more chronic diseases. So comorbidity is the norm, and the mix of co-occurring conditions affects how we treat people or how we think about the approach to diabetes management. Next slide. This is an original analysis that we did nearly 10 years ago, trying to find naturally occurring clusters of chronic conditions for older adults with diabetes. So we basically used a statistical procedure called the latent class analysis to and let the statistical program tell us what were the naturally occurring clusters. And we found 3 clusters. One cluster is indicated by the turquoise, one is indicated by the orange, and one is indicated by the dark purple. So there were 3 naturally occurring classes. And on the x-axis of this figure is a count of the number of comorbid conditions that a person had along with their diabetes. And on the vertical axis is the prevalence of these people in these different, based on the number of conditions they have. And you can sort of see that the turquoise group, they tend to have, their histogram is sort of located to the left of the figure. So they tend to have less than 5 conditions, co-occurring conditions, whereas the class 2 and 3 tend to have about 5 or more co-occurring conditions. So class 1 turns out to be a group that's relatively healthy, and you can sort of see I've written in the bottom the 5-year mortality rate for these 3 classes. Class 1 had a 5-year mortality rate of only 9%. Class 2 had a mortality rate of 17%, and class 3 had a mortality rate, 5-year mortality rate of 33%. So these classes not only differ in terms of what conditions they have, but also their mortality rate. And we've gone on to actually replicate this analysis with the same data set, looking at the same group of people 5 years later. And we find that the same 3 classes exist in this national data set. And what's interesting is that I think the purple class, class 3, tends to have more cardiovascular disease, and class 3 tends to have more of the conditions of that we call geriatric syndromes, such as depression, urinary incontinence, and falls. So there seem to be 2 relatively sick classes, and then 1 relatively large healthy class, class 1. Class 1 represents about 50 to 60% of people with older adults with type 2 diabetes. This classification system is helpful because if we know kind of the prognosis of these different groups, we can make different kinds of decisions for diabetes management. And you'll notice also that class 3 with lots of cardiovascular disease, they're a special group that may benefit from use of specific, many of the newer drug classes that, such as SGLT2 inhibitors and GLP-1 agonists. Next slide. So not only do we kind of know about the natural clustering of chronic diseases among older adults with diabetes, but we actually know a little bit about a bit more in the last decade about the natural history of diabetes for different subgroups. So in this paper, what we did was simply classify people into people in their 60s, 70s, and 80s, and then compared people with relatively new diabetes under 10 years of duration and people with greater than 10 years of duration. So this table shows you the event rate for major complications that we care about in diabetes. And what is surprising is that if you look at the second row, which is basically a hospitalization or emergency room visit for hypoglycemia, what's surprising is how high the hypoglycemia event rate is compared to traditional complications that we think about in diabetes, such as renal failure, eye disease, limb amputations. The hypoglycemia event rate rivals that of the cardiovascular event rates for people in their 80s. And you can see clearly that as people age, the mortality rate rises. And there are other patterns related to age and duration of diabetes that I won't go into. But the main point I want to make is that in modern day diabetes management in the United States, hypoglycemia emerges as a really, which is due to our overtreatment, is a surprisingly high complication. Next slide. And this paper sort of reemphasizes the same thing. This is a national study of all people with Medicare in the United States, looking at the trends in hospitalizations for hypoglycemia and hospitalizations for hyperglycemia, such as diabetic ketoacidosis, over this 10-year period from 1999 to 2011. The blue bar represents the hospitalization rate for hypoglycemia. That is roughly stable or slightly declining to about 600 events per 100,000 person years. The hyperglycemia hospitalization rate, which is in orange, has declined quite dramatically over the same time period. But the point of this paper is that what we typically thought of as the major complication of diabetes is now actually less common than hypoglycemia. So hypoglycemia now is more common among older people as a reason for hospitalization than hyperglycemia. And so that means that our treatments have certainly improved health in terms of reducing hyperglycemia, but it raises questions about why we have such high rates of hypoglycemia in older people. Next slide. So for this section, these are just sort of the main takeaway points. Diabetes is a condition of aging, and this geriatric diabetes population is growing not only in the United States, but really across the world, in both developed and developing nations, in China and India. And so this is something that we're going to have to contend with across the world. And it's important to point out that diabetes and being an older person was a major risk factor for COVID-19. Multimorbidity is the norm. The natural history of diabetes varies by duration of diabetes, age, and comorbidity. And hypoglycemia is now more common than hyperglycemia as a reason for hospitalization. Next slide. So how do we approach lifestyle change and frailty? Next slide. So in the standards of care, which Jose and I help to craft every single year, these are the current recommendations regarding lifestyle change in older adults with diabetes. So optimal nutrition and protein intake is recommended for older adults. Regular exercise, including aerobic activity, weight bearing, and resistance training should be encouraged in all older adults who can safely engage in such activities. I've underlined the two words safely engage. That's the key thing here, is that unlike in younger populations, there are sort of reasons not to reduce calories, and there are reasons to not pursue aerobic activity in the same way that you would do in a younger person in comparison to an older adult. And I'll go into more detail about that. And then in the second recommendation, we say for older adults with type 2 diabetes who are overweight and obese and have the capacity to safely exercise, an intensive lifestyle intervention focused on dietary changes, physical activity, and modest weight loss should be considered for its benefits on quality of life, mobility, physical functioning, and cardiometabolic risk factor control. And this has a Class A recommendation because it's based on a major randomized control, which I'll describe in more detail in the next few slides. Next. So our understanding of how lifestyle intervention affects older adults with type 2 diabetes comes really from this major landmark trial called the Look Ahead trial, which was sponsored by the NIH. It enrolled people with type 2 diabetes, 45 to 75 years of age, who were overweight or obese. Now, a key thing about this trial is that the patients in the trial had to get on a treadmill and pass a maximal exercise test. So think about the person you're seeing in your health center who's older. Could they pass a maximal exercise test? Many of my patients could not. And so when we look at the results of this trial, we have to understand who was enrolled and whether or not our patients could actually do what was required. The intervention was really an adaptation of the diabetes prevention program, both the dietary change and exercise program. And it was actually in many ways more intense. They had a goal that was more ambitious than DPP of 7% weight loss versus 5%. They had a goal of 175 minutes of moderate to intense exercise per week versus 150 minutes per week, which is in the DPP. Patients got a monthly coaching session. They were encouraged to actually cut out a meal or a snack and substitute with these liquid shakes or meal bars, which you can find in a grocery store. This citation provides more detail about the actual program. Next slide. So they follow people for at least 1 year and then less frequently after that. But one key thing I just wanted to highlight is how intensive this intervention was. As many of you probably experienced, it's hard to get people to exercise. And they had a plan A, B, and C for ramping up people's physical activity. So in the standard program, during the monthly calls, they would go through problem solving with the patient and then call people in between the monthly calls to kind of nudge them to exercise. But in Plan B, if they couldn't get the subject to do it on their own, they basically started using the social network of the patient. So they developed a plan to have a friend join exercise. They developed behavioral contracts to exercise more. They provided walking tape and videos to show people how to exercise, or they referred people to exercise classes. In Plan C, they went all out and they gave people shoes, equipment. They referred people to exercise psychologists, enrolled people in health clubs, encouraged people to purchase or lease equipment or provide a personal trainer. Obviously, if you go from A, B, and C, you need more and more resources and money to implement this program. And that's a limitation of Look Ahead. If we interpret the results, many of our patients don't have these resources, or we have to be really clever. And I think Jose will go into some detail about how to create workarounds in our practice environments. Next slide. So Look Ahead was actually considered a failure by the NIH because it didn't achieve the result of reducing cardiovascular outcomes, but all the other benefits are remarkably important to people. It caused weight loss, improved physical fitness, increased HDL cholesterol, lowered blood pressure, reduced A1C levels, and reduced waist circumference. What's also remarkable is that there was a little bit of a reversal in the use of medications. Many patients were able to achieve risk factor control with reduced use of blood pressure drugs, statins, and insulin. So many people were able to come off medications because of the lifestyle intervention. Next slide. So this gets back to kind of the start of this, where I kind of highlighted, that weight loss has to be done safely in the older adult, and that we have to personalize this approach. One key thing is to say that unintentional weight loss in an older person is not the same as intentional weight loss. They're completely different, and we have to be really careful about unintentional weight loss because this happens in older people due to frailty, it happens because of dementia, and certainly due to major conditions like heart failure or metastatic cancer. So when we talk about weight loss, intentional weight loss, that's really, really clear. It has to be clearly described and defined differently, and we can't pursue weight loss in someone who's unintentionally losing weight. Reducing calories has to be done in the right older patient. And the reason is that inadequate nutritional intake, in particularly inadequate protein intake, can increase these two problems that happen in older people, including sarcopenia and frailty. So sarcopenia is the loss of muscle mass where there is a replacement of muscle with fat. And so sarcopenia, which happens in older adults, can be worsened by reduced protein intake. Frailty is this really important syndrome in older adults that's marked by reduced weight, loss of functional status, and kind of this overall syndrome that happens in many older people. Again, we can't really safely reduce calories in that population of older adults. Any exercise program that we undertake in an older adult has to be done safely for a variety of different reasons. Many older adults are at high risk for falls, so we can't just ask everyone to start running or walking briskly without thinking about falls. Many older adults have osteoarthritis, cardiovascular disease, or a comorbid illness like COPD. So we're going to have to think about now, kind of innovative ways to deliver exercise in those settings. Maybe the person can't walk, but they might be able to use an exercise bike. They might have to do exercises in a chair versus being upright. Some older adults may also live in a neighborhood where they don't feel safe. So we can't simply say, go out and take a walk in the park, because that park may not be safe. And so we have to think about ways to have people exercise in their homes, which we've definitely had to do during the 2020 pandemic. And many of our patients, I suspect those especially being seen in health centers, may not have the resources or the interest to join a health club, which is really quite a luxury. Next slide. So I want to highlight a couple of research and sort of exercise program that is endorsed by the NIH, and in particular the National Institute of Aging, called Go for Life. There's the link to the website, but they also have a whole channel of YouTube videos. These are all, the NIA has invested a lot of money into clinical trials of not only aerobic exercise, but also weight training and other safe programs that can be done with older adults. You can refer your older adults with diabetes to these resources, and it could be a guide to doing exercise programming. Next slide. So in terms of lifestyle change, the Look-Ahead trial demonstrates that lifestyle change can improve multiple outcomes that really affect the quality of life of older adults with diabetes. It's really lifestyle change is really the best way to manage diabetes without medications in older people. If you have an older adult who's really reluctant to use medications, this is really the way to do it. Older adults are very heterogeneous, so the lifestyle change program needs to be personalized to account for all of these issues that I mentioned already. Next slide. So I'm going to finish by talking about something that's a little more medically oriented around diabetes goals and management. Next slide. And so since 2012 and since 2012, the American Diabetes Association has endorsed this general framework for sorting older adults and assigning glycemic goals, blood pressure goals, and sort of decisions around statins for 3 classes of older adults with diabetes. And you'll remember that I talked at the beginning of the talk about there being 3 main classes of older adults: the relatively healthy, a group that's relatively complex, and then a third group that's very complex. So the top group is one that we talked about at the beginning, class 1. These are the group of people that are going to live, that are generally healthier older adults with few comorbid conditions who are going to live for at least 10 years. For this group of people, we actually recommend that we pursue the same diabetes goals as for relatively younger patients. And so, for example, for them, their A1C goal would be something between less than 7 to 7.5. This is actually this is the 2012 recommendation. It's now been updated in the last year to 7 to 7.5. So in many ways, the way you think about a middle-aged person is the way you should think about this group of older adults. The second group is a little more complicated. They have co-occurring illnesses. They may have COPD, congestive heart failure. They may have coronary artery disease. And for them, it's actually reasonable to pursue an A1C of less than 8 because we don't have good evidence that pursuing an A1C less than 7 is beneficial for this group of people. So that's a really important thing. Not every patient needs to have an A1C less than 7. And that's certainly the case for this complex group. And then we have a third group that is very complicated with a very short life expectancy. You can imagine someone in a imagine someone who's living in long-term care who has dementia. That's the kind of patient we would imagine in class 3. And for this group, really the A1C goal can be very high, up to 8.5%, because they're not likely to benefit from pursuit of intensive glucose control. And we also allow in this group for more lenient blood pressure targets. So just remember, imagine somebody with dementia in long-term care. There can be more flexibility in their diabetes management in that setting. Next slide. And so in addition to the American Diabetes Association, multiple organizations across the world support this sort of 3-tiered or 2-tiered approach to setting goals for older adults with diabetes. Next slide. So the concepts behind the stratified approach is basically that people have different life expectancies, and there's a lag time to benefit, especially for very intensive glucose control, requiring decades to achieve benefits. And so that's one reason. Another reason is that the relative benefits and risks of therapies sort of shift as people get sicker and have shorter lifespans. In some cases, people have very complicated comorbidity therapy interactions. So patients with heart failure and heart disease, we actually have different recommendations for what drugs to use in those populations, in addition to thinking about glucose targets differently. And function is really important to account. If a person can't adhere to the therapy, and if a person has a very complicated treatment regimen at home, it's not going to be beneficial to keep prescribing more drugs in that setting. Next slide. So the clinical pearls from the standards of care are, we recommend a personalized approach to diabetes management in older adults that requires assessment of medical, psychological, functional, and social domains. We actually recommend screening for geriatric syndromes, including polypharmacy and cognitive impairment. We recommend screening for hypoglycemia and hypoglycemia awareness. The drug selection in older adults is all about avoiding risk of adverse effects. And in some cases, de-intensification of basically overly complicated regimens is recommended to reduce hypoglycemia and polypharmacy. Next slide. Thank you very much. And I'll take some questions before we move on to Dr. Leon.
Wonderful. Thank you. Yeah, so we have a few minutes if folks have questions or comments. If this patient population are folks that you serve, would love to hear your thoughts on that. We'll give it just a minute. Jose, did you have any questions for Dr. Huang? I know that you both work on projects together for the American Diabetes Association, but didn't know if you had any other thoughts or questions for him while we wait to see if anyone has chat box questions.
Thank you, Ariel. Yeah, it was very interesting to see the hypoglycemia issue in the aging population and the need to create awareness. Dr. Huang, do you have any strategies for patients who are over the age of 65, to create either some kind of education or work with family members to recognize some symptoms of hypoglycemia?
Oh, that's a great question. Yeah, so we we have to educate people and their families about what the symptoms of hypoglycemia are. First, I think it's important to establish whether or not the person's ever had hypoglycemia. If they've had it before, and they've ended up in the emergency room or the hospital for hypoglycemia, that's unfortunately a major predictor for another episode of hypoglycemia. And it unfortunately also creates this cycle where people actually can't sense low blood sugars. So we have to teach people about interpreting glucometer readings, but also understanding personally how they feel hypoglycemia. Everybody's a little bit different. Some people feel hungry, sweaty, faint, uncomfortable, and sometimes they have to check the sugar at the time to see where it is, and they need to know key numbers like 54 or 70, and look out for that to detect hypoglycemia. So it's awareness of symptoms, but understanding of numbers also.
Excellent, thank you.
And I'm just curious, Dr. Huang, you have obviously your contact information on this slide, and certainly anyone who is watching the recording, if they have a question directly, they can email you. But I'm curious, for this chronic disease website, what kind of materials or information could folks find here?
Right. The website is basically is for our chronic disease center, which people will find the kinds of research that we do at University of Chicago. It may or may not be of interest, and certainly we on our Twitter feed we have you can follow us in terms of upcoming publications on topics that include geriatrics, older adults. And a lot of research that we do in the Medicaid program, but also in the health center program.
Wonderful.
But I'm happy to answer questions if people want to think of something after this talk is over.
Sure. Yeah, that's fantastic. I don't see anything right now in the Q&A or the chat box, but for the sake of time, we'll go on to some of Dr. Leon's content. But thank you so much, Dr. Huang, for your time.
Thank you. Thank you for having me.
Yes, thank you so much.
Thank you so much.
All right, I'm going to turn it over now to Dr. Jose Leon from the National Center for Health and Public Housing.
Thank you, Ariel. Good afternoon or good morning to you if you are on the West Coast. And thank you for attending this activity. I am going to briefly provide an overview of HUD assistance programs. It's my understanding that we have some public housing primary care grantees as well as other health centers located in or immediately accessible to public housing. And even though the public housing program is the most popular one, we also need to make sure that we have a very good understanding of the other programs, because you may be located close to these buildings or apartments or units where you have people who are receiving help from HUD. So as I mentioned, that there, in addition to the public housing, program, there are two more programs. One is the Section 8 of the voucher program, where people get assistance from HUD and they can select the place where they want to live. And the other one is the multifamily program. This one in particular has a lot of patients over the age of 65. So it's very necessary to know whether in your community you have people who are part of this program. So it's part of the assessment that you can do in your community to make sure that you reach out to those who need healthcare preventive services from your health center. One of the things that is really interesting to see is that not everybody applying to a HUD program actually receives assistance from HUD. Only a quarter of them receives assistance. So make sure that in 2015 or 2016, HRSA changed the way that we are counting public housing residents. And the reason is that sometimes in the community where these developments are located, you also have other people with the same needs, either or being affected by the same social determinants of health, that actually do not live in public housing, but they have exactly the same needs. So the key characteristics of those receiving help from HUD are that 64% of them are from a minority group, 20% are disabled, and 77% are female head. So there are some eligibility issues. These people living in any of these or receiving any of HUD assistance help from these HUD assistance programs need to be U.S. residents. They have to be under the poverty line, and generally they have to be around at least 2 or more people living in the household. Next slide. So in regards to those living in public housing, there are two populations who at least HUD divides them under or in 2 groups. One is non-elderly or non-disabled, but low income elderly and persons with disabilities. And the other one is those who are part of the special needs populations, either those experiencing homelessness, people with HIV/AIDS, or those returning from prisons. Next slide. So this is just, I'm going over, this slide, we presented this slide last session, and just to mention that there are around 433 health centers located in or immediately accessible to public housing, and they provided in 2019 services to over 5.2 million patients. Next slide. The health center population, all health centers reported that around 10% of the population that they serve are over the age of 65. And for those public housing primary care grantees, the percentage is around 9%. Next slide. The diabetes prevalence in public housing is around 9.6%, and when you compare it to all health centers, all health centers reported 9.08% in 2019. Next slide. So this is a very interesting slide, and the reason is that I need you to just take a look at the percentage of those living in public housing who are over the age of 65. We have 35% of them. Of the households have at least one person who is over the age of 65, and around 38% of the household also reported of someone with a disability. This is really important when you have patients with diabetes, because then you need to start thinking about how you are going to provide services to this population. Remember that some of them will have some transportation issues, and then you will have to make sure that the services that you provide are going to this patient who sometimes cannot go to your health center. The other issue the other social determinant of health that is really interesting is that 55% of those living in public housing have less than a high school diploma, which is extremely important when you are going to provide health education and you are going to assess health literacy in this population. Next slide. When you combine the numbers from HUD, the data that they have on their website, 18% of the public housing household report an elderly person who also has a disability. Interesting to know that, again, transportation issues may be reasons why these patients cannot go to your health center, and you need to start thinking about the strategies on how you can reach out to this population. Next slide. As Dr. Huang mentioned, he talk about other comorbidities, and in public housing, we have patients over the age of 65 with at least 2 or more comorbidities, specifically cardiovascular diseases, or we have patients with kidney conditions. In addition to diabetes, 33% of those living in public housing are also current smokers. That this is something that we have also we need to consider, especially because smoking is another factor that is going to affect the diabetes outcomes in this population. So we have several maps on our website showing some of the diabetes rates by county, and specifically if you are trying to develop a prevention program in your community and see how your health center is doing when you compare it to the data that you get from the county health department. Next slide. So one of the strategies that we have discussed with public housing primary care grantees to reach out to the aging population living in public housing is that they are doing group visits. We work with a group of public housing primary care grantees. This is an advisory group where we get some feedback from them. We have some nurses, doctors, diabetes educators, CHWs, providing some information, feedback, and sharing some promising practices. And one of the strategies that is very useful for them is to do some group visits. This has changed now that we have we are in the COVID-19 pandemic. The group visits have been stopped for a moment, or they are working and using virtual visits. But this is a very good strategy on how to reach out to public housing residents and provide some preventive services, not only diabetes prevention services, but for other chronic medical conditions affecting those living in public housing over the age of 65. Next slide. This strategy requires a lot of planning, review. First, you need to know who lives in public housing. There are several ways that you can actually assess, this population. You can work closely with your public housing agency and then get some information about the demographics of those living in the developments close to your health center. The other one that is very useful is to work with your CHWs. They are part of the community. They know exactly where your target population is. And then you can get some information from your current patients and visit the electronic health record just to make sure that when you get to the community, you have all the information that you need to provide health education or diabetes management to those who are your patients and have diabetes. Next slide. So it's really important to know any comorbidity, the treatments or the drugs that they have, and all the strategies that you have used with your patients to make sure that there are no complications or there are not other symptoms associated, as Dr. Huang mentioned. There are other comorbidities affecting this population. So when you're there, you have all the information that you need to discuss the diabetes issues, or if you are doing some prevention, how you can educate your patients over the age of 65 on how to prevent diabetes. Next slide. One of the benefits of these visits is that it's family-centered, is really important, as we discussed earlier with Dr. Wang, the need to have sometimes members or relative members close to the patients. They know exactly some other conditions affecting our population. At the same time, they can recognize some of the complications that a patient can experience, or give you some additional information that sometimes we are unaware of. And it's always interesting to see that if you are close to these developments where you have patients who are either or whose language is not English, and you sometimes will need some interpreters. So this is one of the this is one of the advantages when you provide these visits, because there is more interaction, and at the same time you can get additional information from those living with your patients. Next slide. This is a very good opportunity to also go beyond diabetes. What else your patient may be experiencing that you are not aware of? And as I mentioned previously, is important to see and to have a family member who can say, oh, you know, by the way, in addition to this, he is being affected by this condition. And so it is a very good opportunity to assess hearing loss or cataracts or osteoarthritis or COPD, dementia. Important is oral health. We tend to forget oral health. And in patients with diabetes, this is extremely important. But again, I mean, oral health in general is extremely important for patients over the age of 65 or for the aging population living in public housing. And then the geriatric syndromes that Dr. Huang mentioned, frailty and urinary incontinence, falls, and all the mental health issues that the patients may be experiencing, that sometimes you need somebody else close to them who can provide you with that particular information. Next slide. The other topic that we've been discussing with this group of health centers is the need to provide resources to your patients, to your senior patients, and make sure that you assess health literacy in these patients, and make sure that the information that you are providing is understood by your patients. We've been discussing the use of testing and glucometers, and whether or not the patients understand the ranges, and whether or not the patients can tell you the difference between hypoglycemia or hyperglycemia, or what is their average blood glucose level, or what they are doing, you know, to improve these levels. So it's extremely important to also assess health literacy in this population. As I mentioned previously, over 50% of those living in public housing have less than a high school diploma. And we need to make sure that the resources that we provide are resources that our patients can understand. Next slide. Glucose testing is extremely important, as we mentioned, just to measure, to have a better sense of how patients are doing after providing all the recommendations that we are providing, nutrition, nutrition tips or exercise tips, or the drugs that the patients are taking. We need to make sure that they know how to use the glucometer. We need to make sure that if they cannot use it, you have somebody who can help them, who is part of the household, to make sure that you don't have any of the complications that we just mentioned. Next slide. The health literacy issue, again, is is important. And when you discuss diabetes with patients, in addition to provide verbal instructions, NIH and some of the other organizations also say that is if you can provide visuals, either fact sheets or infographics, or explain to your patients and draw some of the topics that you're discussing, it's very important, specifically for the aging population, so they have a better understanding of what you are discussing. If you are explaining about diabetes and how diabetes and what diabetes is and how you can prevent diabetes and the organs that are involved in the body, it's better to create these kind of drawings so patients can have a better understanding of the disease. And this is a very useful technique, in addition to provide all the instructions verbally. Next slide. We also discussed the language barriers. As we know, there are several people living in public housing who are not native speakers. So we need to make sure that all the instructions that we have and that we are providing are understood by the patients. Health centers have interpreters, those who can have interpreters, and then sometimes you have to rely on family members to make sure that your patients understand the instructions that you are providing to them. So it's extremely important to address language barriers if you are working on prevention in the aging population living in public housing. Next slide. This is extremely crucial as well, and is not only the health literacy, but the how we are addressing numeracy with our patients. Remember that they are measuring glucose levels, and they need to know exactly levels. They need to know, they need to understand symptoms of hypo or hyperglycemia. And the only way that they have to do it that way is by understanding what the average levels are, and how and what they need to know, and keep track of these numbers and report any issues to the clinician or to the health center. Next slide. Another issue that we've been addressing with this advisory group is the medication errors and medication adherence, specifically for those patients who have multiple comorbidities, and making sure that they have a better understanding of the medications that they are taking and what they are doing to assess that they are not that they are on track of all the medications that they take. Next slide. Another recommendations in regards to health literacy is to avoid abbreviations. Sometimes we make mistakes and provide information in some language that probably is not understandable for patients. Remember that all these abbreviations come from Latin, and sometimes it's better just to describe the patient and let them know specifically what you are saying and what you are or how you want them to take their medications. Next slide. Another issue is to also assess food insecurity. This is something that all health centers are doing, and there are some strategies here that we can use. And the idea is just to make sure that we are addressing also all social determinants of health. I'm going to stop for a moment. I know that we are going almost over time. And see if there are any questions. The slides will be available for those who are looking at or who will look at the recording. So, and if you have any questions, you can contact me at any time. Sorry, I'll turn it over to you.
Okay, great. Yeah, we can just go right here to Dr. Leon's contact information. if folks want to look, and certainly we'll send out the slides momentarily so you can take a look at any of the material that we weren't able to get to today. If you do have questions for those watching the recording, there are lots of contact information throughout this presentation that you can be in touch with any one of us if you want to share your thoughts or concerns. And as I mentioned at the start, a SurveyMonkey link will pop up when you leave this Zoom. We'll also email that out to participants just so we get a chance to hear your feedback. Thank you so much for your time and attention today. And thank you so much, Dr. Leon, and for connecting us with Dr. Huang as well. So we thank everyone so much for participating in this 2-session series, and we hope to see you for a future activity, whether that's related to diabetes or another one of the topics that we focus on. Take care, everyone. Thank you.
Thank you so much. Have a great afternoon.